From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Clinical Reviews podcast. Thanks for joining us. I'm your host, Dr. Karen Lasser, Professor of Medicine at Boston University and Senior Editor at JAMA. Today, I am joined by Dr. Karen McLean, who is a professor of gynecologic oncology at Roswell Park Comprehensive Cancer Center and will be speaking about endometrial cancer. You can find a link to the article in this episode's description. Welcome, Dr. McLean, to this JAMA Clinical Reviews podcast.
Thank you very much for having me today.
It's our pleasure. So, to begin with, how common is endometrial cancer, and what are the main risk factors?
Endometrial cancer is now the fourth most common cause of cancers in women in the United States, and it has both an increasing number of cases and mortality. We now realize that about 1 in 32 women in the U.S. will develop endometrial cancer at some point in their lifetime. Major risk factors for endometrial cancer depend on whether it's in the non-aggressive or aggressive subtypes. For the non-aggressive subtypes of endometrial cancer, major risk factors include unopposed estrogen, due to causes including obesity, tamoxifen, and nulliparity. Additional risk factors include both endometriosis and diabetes as an independent risk factor.
And some endometrial cancers can be hereditary, correct?
Yes, that is true. About 5 to 10% of endometrial cancers are hereditary, most commonly from a hereditary syndrome called Lynch syndrome, which is due to pathogenic variants in a number of genes in what we call the mismatch repair pathway. And there are a couple less common hereditary cancer syndromes, one called Cowden syndrome and one called Peutz-Jeghers, both of which have an increased risk of endometrial cancer. Finally, there is some data to suggest that pathogenic variants in the BRCA or BRCA genes can have an increased risk of endometrial cancer.
Mm-hmm. And what are some of the protective factors for endometrial cancer?
So in contrast to the estrogen that promotes endometrial cancer growth, progesterone can be protective. So this includes oral contraceptives that contain a progesterone or postmenopausal hormone replacement therapy that contains progesterone, as well as progesterone-secreting intrauterine devices, and these can all decrease a woman's risk.
Sure. Now, you touched on this a little bit, but how has the epidemiology of endometrial cancer changed in recent years?
Yes, we are actually seeing an increase in both the number of cases and the mortality associated with endometrial cancer. It is now the most common gynecologic cancer and the most common cause of gynecologic cancer deaths in the United States. And so we are very interested in efforts to decrease these numbers.
And it sounds like also with the increase in the prevalence of obesity, there's been an increase in the prevalence of endometrial cancer, correct?
That's correct. And so that is one factor that we think that's contributing. We're also seeing an increase in the other subtypes, the aggressive histologic subtypes, and we have less of an understanding as to why that is the case.
Okay. And how do patients with endometrial cancer typically present?
The most common presenting symptom is abnormal vaginal bleeding, and specifically postmenopausal bleeding, because the majority of women with endometrial cancer are postmenopausal. Increasing data, though, says that sometimes there are other symptoms that are presenting, such as fibroids and uterine enlargement, pelvic or abdominal pain, or anemia. And these less common symptoms can be particularly observed in Black women who have an underlying diagnosis of endometrial cancer.
And in your review, you also mentioned some ways where endometrial cancer can be picked up as an incidental finding. Can you talk a little bit more about that?
Yes, these scenarios are less common but still occasionally occur. The first is a situation where a woman has a Pap test, and a Pap test is designed for detection of cervical cancer, but occasionally will pick up abnormal or atypical cells from the uterine lining that are coming down and out of the cervix. And so a Pap test that shows atypical glandular cells can be concerning for endometrial cancer. We will also sometimes see abnormalities on an imaging test like a CT scan or an MRI that's performed for a different reason, and then it shows that the uterus is abnormal. And finally, In about 1% of the cases when a woman has a hysterectomy, that final pathology ends up showing an endometrial cancer that wasn't suspected at the time of hysterectomy.
Yeah, and I think even more frequently as a primary care physician, we might order a pelvic ultrasound for pelvic pain and see it on that as well, correct?
Yes, that can be also observed in that scenario, yes.
Now, if a patient has a known diagnosis of fibroids, should abnormal uterine bleeding be managed any differently?
This is a really important question because one of the consequences of fibroids is that they can distort the appearance of the endometrial lining on a pelvic ultrasound. So, while traditionally we've used an ultrasound to assess for the underlying risk of endometrial cancer, in someone with fibroids, that measurement of the lining can be inaccurate. And so, for all women with abnormal bleeding, we really need to make sure that we have a tissue diagnosis or a biopsy that helps us know, is there concern for a cancer?
Yes, so you're getting to my next question, which is how is endometrial cancer diagnosed?
So, what we ultimately need is a biopsy of the lining of the endometrium. And this can be performed either in the office, and that's with a small suction curette. It's like a little straw, but even smaller than that, or in the operating room with what's called the dilation and curettage.
And which patients should have an ultrasound?
So, in a postmenopausal patient, an ultrasound can be an initial test to help know whether there's concern for underlying endometrial cancer. And the historical threshold has been an endometrial thickness of 4 millimeters. We talked a little bit about the limitations in the setting of fibroids. And also, there are other limitations, including premenopausal women in whom a ultrasound is not as helpful. And also, it's really important to say if any woman of any age has persistent bleeding, then they should really have a biopsy and not just rely on an ultrasound.
So, to clarify, if a premenopausal woman presents with abnormal uterine bleeding, they should go straight to tissue diagnosis. Whereas if a postmenopausal woman has it, you could do an ultrasound first. Is that correct?
Yes, I would say that that is true. Sometimes the cause of the bleeding in a premenopausal woman is something other than cancer,
Mhm.
but we would like to make sure we're ruling out that diagnosis because, of course, of the severity of it. So, a biopsy is important, particularly in any woman with persistent bleeding issues.
Sure, sure. Now, could you talk a little bit about racial disparities in endometrial cancer?
Yes, this is a very important topic because we mentioned a little bit about the fact that presenting symptoms may be different in Black women, and this includes uterine enlargement, pelvic pain, and anemia. So, transvaginal ultrasound is our initial approach for working up a single episode of bleeding in postmenopausal women. And overall, the threshold of 4 millimeters or less has a very good negative predictive value for endometrial cancer. So, in other words, is reassuring after a single episode of bleeding. However, we have a large study in Black women that says that this 4 millimeter threshold is not as accurate in this population and that it can misdiagnosing cancers in women that actually have an underlying cancer. The other thing we see is that there is a higher frequency of the aggressive histologic subtypes of endometrial cancer in Black women, as well as issues of receiving guideline concordant care in not only Black women, but other underrepresented minority populations as well.
Just want to go back and clarify something. You said that using the 4 millimeter threshold can lead to false negatives in Black women.
Yes, there's a study that showed that. And so, again, one of the things we really want listeners to know is if there are persistent symptoms, the only way to know for sure if there's a cancer or be reassured there's not a cancer is to do a biopsy.
Absolutely. So once you have a diagnosis of endometrial cancer on the biopsy, what does the initial management look like?
So, first line management for endometrial cancer is surgery, and this includes removal of the uterus and cervix, as well as the fallopian tubes and ovaries. This can be performed either by a minimally invasive approach or a laparoscopy, which is small incisions, either robotically or with what we call conventional laparoscopy, or with a larger incision that's called laparotomy. There are certain subsets of women in whom it is okay to keep their ovaries if they are younger and have lower risk disease. And then The last component of surgery is what we call sentinel lymph node dissection. So this involves injecting a dye in the cervix during the start of the surgery and then removing the first draining lymph node on each side of the pelvis.
Now, how does treatment differ based on stage and histology?
When we think of the histology part, we divide endometrial cancers into two groups, the non-aggressive and the aggressive histologies. And this is a very important categorization because it really separates how we're going to treat those patients because of the higher risk of recurrence and the seriousness of the aggressive subtypes. So we are considering both the stage and the histologic subtype in considering next steps after surgery. And then I want to highlight that we're also now thinking about a new categorization, which is what's called the molecular subtype, which is further refining our treatment approaches.
Can you talk a little bit about which types of chemotherapy and some of the newer immunotherapies that are used in endometrial cancer and in which patients?
Yes, so there are two categories in which we will generally use chemotherapy. The first is women with an early stage disease, but a specifically aggressive histologic subtype. And those women will generally receive chemotherapy with two agents. One's called carboplatin and the other paclitaxel. The other scenario in which we generally use chemotherapy is women with advanced stage disease or disease that has spread outside the pelvis. And in these women, we use the same two drugs, carboplatin and paclitaxel, and then generally, in addition, a third agent, an immunotherapy, which has been shown to help in these settings.
And what is the name of that immunotherapy?
So there have been multiple trials. One uses a medicine called pembrolizumab and the other a medicine called dostarlimab, which are both immunotherapies against PD-1, so anti-PD-1 antibodies. One other thing I would like primary care providers to know is that a large percentage, probably about 3/4 of patients who've had a diagnosis of endometrial cancer, have sexual health dysfunction after their diagnosis. And so this is something that we encourage providers to ask patients about and help identify resources to help them. This can include things like vaginal lubricants and moisturizers. Another very successful approach is pelvic floor physical therapy, as well as referral to sexual health clinics.
And what is the general prognosis for patients who present with endometrial cancer?
So still, stage is the most important prognostic factor. And women with early stage disease or disease that's confined to the uterus, the outcomes are very good. So 5-year survival for uterine cancer overall is about 81%. With those women who have localized disease in the uterus, it's about 90%, while it drops to 72% for pelvic spread and 22% for disease that's outside the pelvis.
Mm-hmm. Is there anything else you think generalists should know about endometrial cancer that we haven't talked about yet?
I think the most important other thing is that prognosis can be very good for women who have early stage disease. So diagnosis is essential. And as we're getting to a situation where treatment after diagnosis is so much more granular in the strategies, it's really important that a patient meet with a gynecologic oncologist to really understand the options and the prognosis in detail.
Sure. Well, thank you so much. This has been tremendously helpful. I'm Dr. Karen Lasser. I've been speaking today with Dr. Karen McLean from Roswell Park Comprehensive Cancer Center about endometrial cancer. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.